Okay, can you hear me? Excellent. So let us now discuss head and facial injuries. So let's, without any further ado, we're going to talk about some of the injury types that we're likely to encounter and some of the injury patterns and how we can predict outcomes with these individuals and how we can appropriately treat it. So you know about the brain, most important organ in the body. It requires a lot of protection. It functions off of oxygen and glucose. It has several, they say, hard and soft wrappings. You know what? Let's get a little more detailed than that. So you start off with, instead of just talking, let's get a picture going here. We start off with your hair, your scalp, your skull, the meninges, and then the brain itself. Let's get a nice little picture happening here. There we go. Like I said, these slides are a little bit barren, so we're going to have to work on that. Open There we go. So there's a slightly better example. So you got your hair out here, then you got your skull, then you have your meninges, your 3 layers, and then you have the actual brain itself. It needs a lot of protection because if it gets damaged, then you don't work so well. All right, so we have your scalp, starts off with hair, skin, your subcutaneous tissue, just like any other tissue. Let me see if I can get a better diagram. There we go. Here we go, that's better. Yes, that's what I want. Got it, perfect. Okay, so your Galea aponeurotica, that is, if we zoom in, there she be, right there. This is a very tough, sinuous membrane. So first you have your hair follicles, your epidermis, your dermal tissue, your subcutaneous tissue, and then down here you have your Galea, I can't even pronounce it. I'm going to butcher it. So it's on the top of your skull. It starts off with the occipital bone. It moves its way forward. And it's basically a really tough sinuously fiber. There we go. And then we have your standard loose connective tissue and then your periosteum, which I think is on here too, is it? Oh, no, it's not. Okay, let me find it. Sorry. There we go. There, that's a great example. There we go. So you have your skin, periosteum, bone, dura mater, arachnoid, pia. So by the way, if you need to remember for a test question, in order from top down, it is dura, arachnoid, pia. Pia is closest to the brain. Arachnoid's in the middle. Dura is the one closest to the skull bone. The other stuff is more nice to know than anything else. So skull has officially 28 bones. Those of us that have skull fractures, I can make the argument have an extra free-floating bone. So you have the 6 bones. You have your auditory ossicles on both sides. This is your ear canal that allows you to hear. And you have 6 bones in the ear, and then you have another 22 throughout the rest of the head. Now, that being said, you will note that there is an assignment On this module, chapter 21, to label the skull, it's not active right now because I have to finish typing in some coding on it, but expect it to be probably operational today or tomorrow. You have until January to finish it, but try to get it done sooner than later, and it'll be based heavily off of what you're seeing here. So your cranial vault. This is comprised of 8 different bones. You have over here your parietal bone. They're bilateral. They're on both sides. You have your temporal bone over here. Again, you have 2, 1 on each side. You have your occipital. That's just 1 at the back here. You have your frontal, just the 1 at the front. And then you have your sphenoid. You also have just the 1. And then lastly, you have your ethmoid bone. These are ones that you would see interiorly, so you won't see them right here. So here's some of your skull joints and sutures. Remember, we were discussing the fontanelle and how that's an early indicator of dehydration in a pediatric patient. We have your suture lines here. By the way, if someone's talking about the sagittal plane on a patient, if they're talking about anatomical landmarking, they're referring to this, the sagittal suture line. This would be going right down the center of the body. So if someone's talking about anatomical landmarking and they mention the sagittal plane, that's what you're looking for. Remember, on kids, this may take several years for it to fully form. It's cartilaginous structure, and the rationale for that is as you grow and your body changes shape, these allow those skull plates to move around a little bit and release some pressure. So here are the interior aspects of the cranial vault. Now, yes, technically you do have more openings than just the foramen magnum, but realistically, this is the only thing the brain can really sub itself through when it begins to herniate from increased intracranial pressure. Here are some of the major compartments. You will have to be able to identify on a diagram where this is, but you don't necessarily have to go through all of these. You definitely have to know where the foramen magnum is. I want you to be able to roughly approximate where a basilar skull fracture would be located. Where is our crystal gallery? There it is. So this is a fairly prominent bony ridge on the anterior or the frontal part of the skull. This is where a lot of the meninges attach to. You can see here in the diagram, this little, you can see how this isn't smooth anymore. It's got a lot of points where it can adhere. That's where the meninges are connecting to on the very front. Your cribriform plate, where are you? Here you are. Here's your cribriform plate. There's a lot of little openings here to allow for olfactory nerve filaments to the nasal cavity. And of course, nasal cavity would be just on the other side here. Here are the sinuses. Some patients have larger ones than others. In my case, where I had my depressed skull fracture, that shattered one of the sinuses. In fact, if everyone's okay with it, I will show you all later on today the CT scan that I had. So here's the base of the skull. Here's from the underside looking up, as if we were magically inside the spinal column looking up. Here is your maxilla. That is above the mandible. This is the maxilla. This is what we're looking at here. Your palatine bone over here. If you're having a basilar skull fracture, generally you're getting this fracture over here. You can palpate your external occipital protuberance. Mine's fairly obvious, right at the back of the head where I palpate it. There's quite a bit of complexity here, and you can see a lot of it here. Here is where your jugular vein will go through. You can see the little opening there. There is your carotid canal where your carotid arteries will go. So the jugular and carotids are side by side. Your hard palate here, unless of course yours didn't form appropriately. This is where it's found. And your zygomatic arch, aka this is the bone that moves along the orbit alongside here. So this is where we're palpating for that zygomatic arch. So here's your zygomatic arch, and here's your zygomatic process. This is where we're palpating when we're doing some of our assessments, and this is also where we're going to put in our hands when we're doing that modified jaw thrust. So this is also part of why, if a patient has significant facial injuries, we want to be careful. We don't want to be messing around with facial bones. Now there's 14 bones here in the head. Um, these ones outside don't contribute to the cranial vault. So you can actually have all of these blown away by a shotgun and you can still have an intact cranium. I say this because I've had the misfortune of transporting someone who had exactly that. Their mandible was gone, the maxilla was gone, the orbits were gone, their eyes were obliterated, but they were still alive and their brain was fully intact. So it was very, very interesting experience for that call. So the function of these facial bones, this is to, one, allow you to masticate, which is the fancy word for eating, protects your tongue, protects your airways, provides structure for the nose, provides a socket for the eye, and here you can see your ear canal once again. So we have some major nerves. You have your trigeminal nerve. This is also known as your fifth cranial nerve. It branches into the ophthalmic nerve, maxillary nerve, and your mandibular nerve. So it innervates quite a bit of the face. You have your, aka the facial nerve. This is the seventh cranial nerve. It supplies the muscles for facial expression. So that allows you to smile, to frown, to glare. Ophthalmic nerve, this supplies the skin of the forehead, the upper eyelid, and the conjunctiva with nerve innervation so they can move. And then we also have your maxillary nerve. This supplies skin on the posterior part of the nose, the lower eyelid, cheek, and upper lip. There are, if memory serves, a total of 7 cranial nerves, right, Patricia? Yay, I remembered something from nursing school. It wasn't a total failure for me. Then also lastly, your mandibular nerve. This supplies the muscles for chewing and the skin of the lower lip, chin, temporal region, and part of the external ear. So we have a fairly extensive blood supply to the face. It's primarily fed via the carotid artery. It has some arteries that will branch off of it. Some of the branches are your temporal, so that's along here, your mandibular artery, down in here, and your maxillary artery branches along up in here. Now, these tend to bleed fairly significantly when injured. So facial bleeding can be a very visually disturbing thing. Patients often are rather panicked about it. Friends, bystanders, family are often scared out of their wits because it's highly vascular. However, the majority of the time, it isn't overly life-threatening. We want to ensure that we don't have any airway compromise. Like I said, facial injuries, they can be very visually dramatic, but generally not overly life-threatening. So let's talk about our orbit. Orbital floors are surprisingly easy to fracture, as are orbits, surprisingly enough. You have a fair bit of innervation here, so nerve damage can be fairly extensive. There's a lot of superficial nerves. Your third cranial nerve, come here, mouse, extends up and along here. This is what innervates your eye and causes motion of the eyeball by innervating all of the muscles, and you can see the muscle cross sections here around your orbit. These are what attach to the eye and innervate them. You have a lot. Your optic nerve, this is your second cranial nerve. This would be in behind here. This is what attaches to the eye. This is what provides your sense of vision. So here for the nose, a lot of people think this is a bone. This is just cartilage. Your vomer is in behind, and that's what physically attaches. Your sinuses are actually quite large and extensive. This photo gives you a good idea of just how large they are and how they extend throughout your face. The nose just reminded me of something. So we know that the sinuses take up a lot of space, but does anyone here know why we call certain teeth the eye teeth? All right, Cody, get ready for this one. That's why we call it the eye teeth, because it extends all the way up there. Pretty profound, isn't it? So anyway, getting back on the track. So this area is also highly, highly vascular. We have along the turbinates here a lot of superficial vessels. This is part of why when we inject something like a nasal atomizer and we spray medication into the nares, it's able to be uptaked and absorbed to the body very quickly because it's a highly vascular area with a lot of superficial vessels. And this is also part of why we often feel like we just have this never, when we get a cold and we have a runny nose, and it feels like, why does it never end? Why is there so much snot? Well, because there's a large, large, large area for this stuff to pool. Absolutely profound amount of space. So we all know what our mandible is, right? Yep, there you go. Make sure you know your temporal mandibular joint is up over here. Don't be afraid that when you have a patient that you do a jaw thrust on that you accidentally dislocate it. We should all remember the hyoid bone that I displayed to you guys earlier. That being said, let me just call it up one more time so you can get an idea where it is. So here's your hyoid bone. It provides structure to your tongue. It provides structure to the trachea and the larynx. It is free floating. It is one of the only true free floating bones in the human body, but it's still technically considered to be part of the upper airway. I'll give you another example to see where you can see where it is a little bit better. There you go. So this is part of why whenever cops or corrections officers are doing a chokehold, we're always mildly concerned for the potential for airway compromise, because if this is broken, then you've lost a lot of that structural rigidity it provides to the tongue and to the larynx and upper elements of the trachea. So that's part of why we get pretty concerned. Just note that if you have to deal with a patient that's been in a takedown, you should be mildly concerned that it may be involved. So let's talk about the eye. This here's your globe. This is where your optic nerve is over here, and your ocular motor nerve will innervate these muscle tissues. On a labeling exam, you should, yes, often it is actually, depending on where they have the news. So if they have it further down, it might not be, but generally if they have it fairly high up, then yes, that can definitely be a concern, and that's part of why airway management is of critical importance on these patients. So if anyone didn't see the text, because I've learned since that the videos don't always show these, Patricia asked, is hanging, in a hanging, is the hyoid bone affected? And I would say it can be. That being said, out of the 20 hangings I've been to, I think it was only fractured maybe 4 times. That being said, definitely it can be. So anyway, be able to identify these major structures on a labeling diagram. So I want you to know this is where your pupil is. I want you to know this is the iris. I want you to know where your conjunctiva is. I want you to know where your cornea is. And I want you to know where the sclera is. What is the sclera? It's a nice, pretty white stuff that we look at. We want you to know what the conjunctiva is. This is your mucous membrane that covers your sclera and internal surfaces of the eyelid. Your cornea, this is the transparent anterior portion of the eye that overlies the iris and acts as a focusing lens. Your sclera, that's the white of the eye. This, if you see it red or yellow, this can tell you something clinically. Yellow, probably jaundice. Red, probably petechial hemorrhaging. Can be a sign of Crest syndrome, can be a sign of head injury and others. You want to know what your iris is. Clinically, not overly concerning generally. Your pupil, very great clinical importance. Constricted pupils can indicate you have an opiate overdose. Dilated pupils can indicate brain damage, brain death, or a overdose on stimulants. And then, of course, your retina. This is back over here, a incredibly amazing structure, 10 layers. and with photoreceptors, and this is how we interpret light as it hits the retina, and then the brain's able to interpret what you're seeing. Let's go back to this one for one here. There's a couple of chambers here. You have your anterior portion of the globe. This is comprised of your iris, your lens, your cornea. Then we have your posterior chamber. This is filled with a lot of fluid, mostly vitreous humor. This is what provides shape to the eye. If you have excessive amount in the eye and you have too much pressure, this can lead to macular degeneration. Let's see here. Do we need to go over types of vision? So there's, according to the textbook, I can't remember what page it's on, 3 something, I think. You have 2 different types of vision. You have your central, this facilitates your visualization of objects directly in front of you, and your peripheral vision. This is how you visualize lateral objects while still looking forward. This is important to note. Some people with certain disease processes, they will lose their periphery but still have central vision. Others will have the inverse. They'll have an absence of central vision, but they'll still have peripheral. My Uncle David, for example, he has an absence of central, but he still has peripheral. That's why when he's talking to you, he'll always be turned so he can still see you, just he can't see what's directly in front of him. All right. And we've already discussed your 2 chambers. Your anteriors, you've got your aqueous humor. Your posterior, the larger one, is filled almost exclusively with your vitreous humor. Oh, yes, there it is on the slide, your central and peripheral. So that covers that one. Any questions so far? No? Good. So tears. This is your lacrimal ducts over here, your lacrimal gland. This is what creates your fluid for tears, drains into these little ducts. Everyone thinks tears are down here. No, the tear comes down across the eye, the fluid covers the eye, then pools down here, and then usually pours out on either side. This is part of why we say cry it out, because people always think, oh, the tear starts down here. No, it starts above, and then it does, and in any way, essentially clear the front of the eye with fluid, and then it drains out. And the tears also moisten your tissues around here as well. So moving on to the ears, you have 3 primary anatomical parts. You have, what time is it? Okay, you still have time. Good. You have your pinea, your external auditory canal. Here's your pinea, this is the ear. Here's what we call the tragus. Your auditory canal is here. Then you have your tympanic membrane, aka the eardrum. Your middle ear, this is where, from here, from basically a millimeter past tympanic membrane and out, that is your outer ear. You often find a lot of earwax in here, by the way. And then from the tympanic membrane going this way, you have your middle ear, that's here. This consists of your tympanic membrane and the ossicles. This is some of the bone structure here. So you got your staple over here, your incus over here, malleus over here. This is an incredibly intricate structure, part of why we want to protect our hearing. And then lastly, over here is your inner ear. This consists of your cochlea and your semicircular canals. So let's give me a quick second to show you. This isn't a you need to know, this is just a cool thing. That's what the inside of it looks like. So you can see all these hundreds and hundreds and hundreds of little hairs. And then in here is fluid. So as the fluid maneuvers through here, it moves your hairs, and this is what gives you that sensation of balance and movement. So that was kind of cool. Any questions so far? Nope? Okay. So, sound waves. And let's go back here. So, let's go back to the diagram. So, sound enters through the ear, through your pinea. This is out here. It gets refracted, moves down into your auditory canal, hits your tympanic membrane. Tympanic membrane goes and vibrates. And that is what's activating these bones here and causes them to move. Now, when they move, this is translated to your cochlear duct over here, which then sends that fluid and it moves around in your cochlea. And this is what's giving us that sensation of sound. Now, also any movement, again, also is activating those hairs and it gives us a sense of balance or lack thereof. So let's go back here. So there you go. Enters the ear, goes to the auditory canal, hits the tympanic membrane. The tympanic membrane vibrates, translates to the cochlear duct. Fluid in there vibrates, stimulates the hairs, goes to the brain, and yay, everything works. So here's one more time your diagram. Sound enters here, moves into the ear canal, hits this, vibrates away, moves this bone, which then moves here, which rams into the side of here, sends the fluid down and moves around inside, and then it goes up and to the brain through your nerve right here. So that should be clear as mud. So teeth. The normal adult has, on paper, 32 teeth. You have your primary teeth. These are lost in childhood, also known as deciduous teeth. These are distributed across your mandibular and your maxillary arch. For reasons I don't quite get, we have them identified into 4 different sections. You have your central incisors over here. You have your lateral incisors over here. You have your canine teeth. These are the sharp, pointy ones. And then you have your premolars, and then you have your actual molars. So clear as mud. We all know what teeth are comprised of, I believe. So you have, here's your crown at the top. You can have 1 or more cusps. Those are these little depressions in here. Below the top, the crown, you have your root over here. You have your pulp cavity, which is in here. This is what contains the blood vessels and some of the connective tissue inside the tooth. Your dentin and enamel on the exterior, dentin on the inside. These are what protect the pulp cavity. There are a lot of nerves, and it is incredibly painful to an individual if you happen to, for example, get a root canal. You will know it will hurt. You don't want that. And then, of course, you have your sockets that the tooth fits into, and you have connective tissue that holds it in place. So that's why teeth aren't 100% rigid in their sockets. They do move a little bit. So I've always found it very confusing that it's spelt and pronounced alveoli, just like in your lungs. I've never understood the rationale. It's very confusing. Alveolar ridges, these are those ridges in between the teeth. So that would be, an example would be right here on both sides of the teeth, and that's what forms their sockets. So why it's named that way, I've never understood, because it just confuses people with the lungs. Now, mouth, this is where our digestive process begins, and it begins with mastication, that word I used earlier that implies ar, ar, ar. That's your grinding, crunching, gnashing of your teeth. Now, your salivary glands in here are producing saliva. This is the very beginning of the chemical process for digestion. Food is mixed with the secretions in the saliva as you eat it. Your tongue, this is what is forming your taste. And then, of course, using the tongue and the mastication action moves food in from the mouth towards the posterior oropharynx, where it then hopefully moves down into your esophagus with your epiglottis, closing over the trachea, preventing food from going inside where it doesn't belong. Just for the heck of it, your 12th cranial nerve will be activating the motor function for your jaw and for your 12th. Is that right? I thought it was 7. Am I wrong? No, it's 7 in the face, 12 overall, I think. Right, Patricia? can tell she's looking. So yes, it is 12 cranial nerves in total, 7 that innervate to the face. Okay, good. Anyway, so again, tongue attaches to the hyoid bone. If it's fractured, if it's damaged, that will obviously cause potential airway obstructions with the tongue. So like I said, you have your 12th cranial nerve. This is the motor function for the tongue. And then the 9th, this is what's getting the taste of your tongue, and it activates your your salivary glands. Excuse me. This also, you also have your trigeminal nerve. This provides motor innervation to the muscles for mastication, so the muscles up and along here that attach to the mandible. And your 7th cranial nerve, of course, supplies all of the nerve function to your face. Before we get into that, there are 3 different fracture types to go over here.
The Leforts are diagram 2124. About 4 after where we were, I think. They're there.
Oh, there they are. Okay, good. I skipped right by them. So we know that our hyoid bone is up here. You have your thyroid over here, your thyroid cartilage. Then over here you have your cricothyroid membrane and your cricoid cartilage. These are those semicircular rings going down your trachea, providing some structure against the musculature that is anterior over it. Don't forget you have your carotid arteries and your jugular veins as well. So you do have other vessels as well. There's vertebral arteries as well and veins, but the ones that we are most concerned about, because the jugular venous distension or flattened neck veins can give us a clinical presentation, and we can palpate our carotid arteries here as well to determine the patient's level of perfusion. So the goal of these arteries, these provide the oxygenated blood to the brain, and the veins, of course, bring deoxygenated blood down into your superior vena cava to go to the heart so it can be pumped back out into circulation. Now, injuries to these arteries and veins can be catastrophic, can be fatal. They can lead to cerebral hypoxia, cerebral infarction when the brain begins to die, air embolisms, and permanent neurologic impairment. So here's another surprisingly good example of some of these key structures. So you can see you have your main common carotid artery. This is what is providing cerebral perfusion. Now it branches off here into another carotid sinus, and this also feeds some of the vasculature in your spinal column and the cervical spine. Here is your subclavian. This is a very, very, very large vessel that, as the name implies, is below the clavicle. And just be able to make note of the location of your carotid artery and some of the things it is perfusing. For example, perfusing your thyroid, perfuses a significant portion of the face. And that's also part of why facial lacerations are so profoundly visual, is because you have this direct blood supply. So the aortic arch, you have the aorta, it arches, the top of that arch, you have this almost immediate blood supply with high pressure coming directly off of the heart. And that's part of why a facial laceration visually looks like it bleeds so much. So here's some of the other major vasculature. I know it says arteries here, but these are actually all veins. So here's your superior vena cava. This is where all of these vessels drain into. So the vessels from your arms drain into here. The vessels from your skull, from your brain, they all drain into your superior vena cava. Just be able to make note of some of the vasculature here. I've already discussed what some of these injury patterns can cause. So let's continue on. So within your cranial bulk, the brain takes about 80% of the space. Your cerebral blood This takes up another 12 out of your cerebrospinal fluid, or CSF, which is that straw-colored, golden-looking fluid that we can test for if we place a dressing over the ears, sometimes over the nose. And if we pull it away and it has that halo look to it, we know we're in some serious trouble. Now, some of the major, well, I guess I should talk about this. So the brain uses a lot of the body's glucose. It comprises overall a very small percentage of the tissue in your body, but it consumes a disproportionately high level of glucose. It also consumes a disproportionately high amount of oxygen. Now, it says there's no storage mechanism for oxygen or glucose. Now, it is correct that there is no storage mechanism for oxygen in the brain, and technically correct that there is no storage mechanism for glucose in the brain physically itself. That being said, we at the PCP level have a hormone that we can administer. This is called glucagon. So this converts the stores that are in the liver into systemic blood glucose, which allows that to enter cerebral circulation. All right. So this is part of why when we have a cardiac arrest situation, we need to ensure that we're doing really good CPR so we can make sure we are perfusing that brain. So here's some of the regions here. You have your cerebellum down here. You have your cerebrum over here. Your brainstem, this is the medulla oblongata. This is what's also known as your, quote, reptilian brain, as they say. And then lastly, your meninges. So you have your, starting from the skull down, your dura mater, your arachnoid, and then lastly, the one closest to the brain is your pia mater. So when you have a insult to the brain that causes the brain to swell, or you have a intracerebral hemorrhage, then the brain gets compressed and it wants to go somewhere to get away from this pressure. Now, if you happen to have an open skull fracture already, sure, the majority of that pressure has already been released, but otherwise the brain will begin to herniate down through this hole, our foramen magnum, which is not good for our brain. It'll cause catastrophic damage to the pons, to the cerebellum, to the medulla oblongata, and that can cause irreversible damage depending on how long we've let it go for. So your cerebral cortex, this is your largest portion of this cerebrum. It regulates your voluntary muscle movement and your level of awareness. Injury to the cortex can lead to paresthesia or numbness, weakness, and in certain cases, paralysis of your extremities. Now, one thing I forgot to mention is if you look at the brain from above, it is divided into a right and a left hemisphere. And one thing I should also mention, that if a patient is having an infarction on the right side in your brain, whether it's from a TIA or a CVA, you'll be affecting the left side. If you have a left-sided brain infarction, it'll physically affect the right side of the body. So it's always the opposite side. Now, if we talk about do we have okay, this we'll get into a little bit more detail. Great. So your higher functioning, such as reasoning, are over here in the anterior portion of the brain. Don't forget, it is divided into they say a longitudinal fissure. It is connected on both sides to the corpus callosum. Your cerebral cortex, this is one of the physically largest areas of the brain. And I mentioned earlier, controls your voluntary skeletal movement and helps regulate your awareness level. Now, your occipital lobe over back here, this is responsible for processing all of your visual sensations. And then your temporal lobe over here, this is where they believe that your speech center is on about 85% of people on the left side, they say, and also controls some of your long-term memory, hearing, taste, and smell. All that being said, out of all the structures in the body, I think we can fairly safely say we understand the least about the brain. Now, see if I can get a good picture of a corpus callosum. So here's one. So they have resected the superficial element of the brain. It's been resected down, and now you can see that corpus callosum, that bridge, and all of the fibers that extend through it to access other regions of the brain on both sides. So that's that cognitive bridge, that element of the brain that allows both sides to talk to each other. That being said, do either of you think it is possible to survive a radical hemispherectomy where half of the brain is physically gone? Yes, Patricia is absolutely right. It is completely possible to have a situation where, and it doesn't work very well in adults, doesn't work well at all. But if you're a really young kid, like 3 years old, you can have radical hemispherectomies, and the brain somehow is able to reconfigure itself and take over the duties of the other half. There's also, I found this to be profoundly interesting. So this individual with the profound amount of brain loss, in fact, approximately 90% of this individual's brain is missing in action, MIA. Hold on a second. There he is. So he had a situation where, for reasons that no one quite understands, the ventricles in his brain started to fill up with more and more fluid, and the pressure began to destroy it. His only complaints have been mild weakness in his left leg, and still fully cognitive, and over 30 years of fluid buildup caused destruction of his brain. So yeah, 90% of it MIA, still cognitive, still able to function in society. So there are certain individuals, I wish I could say, he can function, what's your excuse? But we can't say these things. Now, that being said, any questions so far regarding our cortex and our hemispheres? No? Yes? Maybe? Remember,
That guy, would a stent have helped him?
so he had a stent put in when he was a kid. The
Yeah.
stent failed, and he currently has one to prevent any further erosion of his brain. Because now that he is starting to become symptomatic with a lack of, some impairment to his legs, it's either that or he was going to suffer from catastrophic issues. So he didn't have much of a choice. So here's your diencephalon. This is between the brainstem and the cerebellum. It includes your thalamus, your hypothalamus, your epithalamus. Depending on the individual, it can be a bit larger. Here is, remember that bridge I showed you? Here is your corpus callosum. This is a representation of it. Here's your pons. Here's your medulla oblongata. I'm just call this back again. So your diencephalon includes all these structures, processes, sensory inputs. The thalamus is believed to greatly influence a person's mood and certain movements that are associated with fear and rage. Your subthalamus, this is controlling all of your motor functions. Your epithalamus, well, according to the lecture notes, they are uncertain what it really does. And like I said, out of all the structures in the body, I think this is the one we understand the least. So your hypothalamus, this is the most inferior portion of the diencephalon down here at the bottom. It is vital in the control of many body functions such as heart rate, sexual development, hunger, thirst, vomiting, regulation of the deep sleep cycle. So when I say heart rate, This is why, if you remember me mentioning at the very start of our lectures last week, my second ever patient was a 12 gauge shotgun to the head. And I'd say from here up, gone. Just not physically there anymore. But from here down, still intact. But as the brain began to fail and parts of it began to fall off, eventually enough structural damage and hypoperfusion to the hypothalamus occurred that he went into a state of cardiac arrest. So now the cerebellum, this is sometimes considered to be your, quote, athlete's brain. It's responsible for maintenance of your posture, your equilibrium, and coordination of skill movements. Now, what's interesting to note is whenever you have a flash of epinephrine in your fight or flight response, you lose all of your fine motor control. So your brainstem, the medulla oblongata, this is what connects to your spinal cord, consists of your midbrain, your pons, and your medulla. So here's your midbrain, your pons, and your medulla down over here. So your, how do I phrase this? Your brainstem, this is what consists of your reticular activating system. This is responsible for maintaining consciousness, especially with level of arousal. This is part of why we're able to see decerebrate and decorticate activity in certain circumstances. These indicate damage to this area. It helps control your heart rate, your blood pressure, and respiration. This is part of why as the brain begins to herniate through intracranial pressure, we can see fairly specific respiratory and cardiac patterns. Your midbrain, this is again directly below our diencephalon here. This is your midbrain. It is the smallest portion of the brainstem, contains your basal ganglia, so this coordinates all of your posture and movement, and your limbic system, so it influences your emotions, your mood, sensations, and pain. And then your pons, there we go. This is somewhat continuous with your spinal, lies just above your spinal cord, just below the midbrain. So this is the midbrain. Here's your pons here. Contains, they say, numerous important nerve fibers and control sleep and respiration. But again, it's another classic case of we think we know what it does, but we're not 100% sure. And then lastly, your medulla. This is down over here. This is directly above the spinal cord and leads directly into it. It is continuous with the spinal cord. It serves as a conduction pathway for all the electrical impulses that are coming up to the brain. This coordinates all of your neurovascular innervations, controls blood vessel diameter, breathing, swallowing, tremendous amount of activity, and your vagus nerve, which is one of the largest nerves in the body and extends throughout, innervating the heart, intestinal tract, and many, many things, starts here from the medulla and goes down. Oh, looks like I yapped about this stuff. There we go. Here's your midbrain. Here is your limbic system. This is what coordinates your movement and your posture and your emotions and sensations. And I said I already discussed all of this here. So now we're going to talk about the meninges, which I've mentioned several times, but it's going to be a little more detail. So here you have your dura mater. Here is the arachnoid. This is what looks like a spider's web. And then lastly, the pia mater. This is the one that is the one that touches your brain tissue. So the dura mater, this is that really strong outer fibrinous layer. It covers the entire brain. It folds and it separates your cerebral hemispheres from the cerebellum and the brainstem, and is attached to the inner wall of the skull. If we remember earlier slide where it shows your anterior portion of the skull, remember there was a spot where it wasn't smooth and it had all those little holes. This is where it's connecting to your arachnoid. That's that second meningeal layer. It looks like a spider web. lot of vasculature within that layer. And that's why we often have subarachnoid hemorrhages, because it's highly vascular in between those two layers. And then lastly, the pia mater. This is that really thin, translucent tissue, and it adheres directly to the brain. So the meninges are suspended in your cerebral spinal fluid. You have meningeal arteries located between the dura mater and the skull. You can have a subdural hematoma. You can have a hematoma in between the dura mater and the skull. And then, of course, your cerebral spinal fluid flows between ventricles of the brain. The ventricles are not entirely unlike the ones of the heart. They don't necessarily pump fluid, but they definitely do act as a reservoir. See if I can get a better example of that, because this slide is blank. So here are some of your ventricles in the brain. These are those reservoirs for your cerebral spinal fluid. And it helps generate the CSF and move it throughout your cranial vault in the brain. So here is your 4 ventricles. So at least you can visualize it a little bit better now. So facial injuries. You want to note the mechanism of injury. You want to note how much force was involved. You should always be prepared for airway compromise and for a altered mental status. You can have impaled objects. I remember Randy talking, I believe it was yesterday, about whether or not you would remove one in the cheek. And here would be an example of if it is impacting your airway or impacting the ability to manage your airway, it comes out. If it isn't impacting your airway or your ability to manage it, then you would still leave it in place. Use your discretion as needed. So facial bones can absorb a lot of kinetic energy. Some of the symptoms of an impact ecchymosis, this is fancy word for large bruising. You can have lacerations. You can have swelling, pain. You can have a lot of fractures, especially around the orbit. A depressed skull fracture around the sinuses isn't overly concerning, but a depressed skull fracture anywhere else in the skull is of great concern. Significant soft tissue injuries to the face can obviously significantly impact your ability to have a patent airway. Any patient with a closed soft tissue injury to the face, you should have a concern for potential airway compromise. And like as with impaled objects, use your discretion whether or not you remove it. If it impedes your airway, get rid of it. If it doesn't, leave it alone. So nasal fractures. So they say nasal bones are structurally unsound. Well, let's be honest. The vomer is not exactly the most rigid structure. Let's get a quick look of one. There's your vomer. There's the bone that the nose is attached to. It's as you can tell, it's a fairly small structure, and it's not very robust. So let's also open up this in a new tab. Here we go. So now we can see that this is a fairly small structure, not exactly the strongest structure known to mankind. So any significant insult can cause it to fracture and dislocate and move. Now, epistaxis, fancy word for nosebleed. You can have fairly significant bleeding. Now it says most common facial fracture. Yeah, I broke my nose. I think it's three or four times. I can't remember now. More than enough. Actually, no, I think the 4th time was my accident in the Philippines. So yeah, it's been broken 4 times now. Surprisingly, still fairly straight, mostly. Some of the signs and symptoms of this, you will often, and in my experience, I'll have almost immediate swelling here, followed by, if I were to move it, I would hear that crunchy bone sound like, ah, no, make it stop. You will often note it'll be displaced to one side or the other. The very first time it was displaced fairly significantly. The very first time I was in the high school hardball team, yes, I was thin enough to once be a good baseball player, and coach called for balls in, and they were supposed to throw them all back to the home plate. And this one guy who was a bit of an asshole aims it towards my face and whips it at me. And because I'm throwing mine back to home plate, I'm not watching what he's doing, and it connects directly with my nose because I did not see it coming. So that was a bit of a hard one. Second time I slipped on ice, and I had a car door open, and I landed. And so if this is the top corner of the door, I slipped and connected with it directly here. Had I been off in either direction by a millimeter, I'm certain it would have gone into my eyes. The third time, I was assaulted by a patient who my partner had given them what we called the Kamsack cocktail, and that's where we would give them Narcan and Flamanil to overcome whatever overdose they happened to be on, and they got up and started assaulting me out of the blue. And of course, the last time on a motorcycle at speed versus pole won, Leslie 0. So those are the times I've broken it. And yes, nosebleed epistaxis is very common. Now, when I slipped and hit the car door, oddly enough, even though it was obviously a dislocated fracture, it didn't bleed. And nor did it when I broke it again in the Philippines. But the first and the third time, yes, I had very profound epistaxis for a prolonged period of time. Now, mandibular fractures, here's your mandible down here. This is the second most common facial fracture. Usually anytime, yours didn't bleed either, okay. Well, that's good. We don't want it to bleed, right? So this is second only to nasal fractures in frequency. It's the second most common fracture to the face. Anytime you have any significant blunt force trauma to the lower third of the face, you're likely to have a mandibular fracture. You can also have dislocations up here in your temporal mandibular joint. So if you have enough force to fracture this, chances are you had enough force to also dislocate up here as well. You can have malocclusion. This is a misalignment, so that can be from this. If you look at my teeth, you can probably see better in person. Mine aren't as straight as they used to be because of the forces from that impact on the post that I encountered. So I actually had a couple of fractured teeth as well. The dentists have tried to fix. Hopefully they will stay in place for a while. You can also have dislocations from yawning really, really widely. And I've actually had a patient who allegedly this was what she was doing. She was yawning and her jaw was locked open. And she was unable to move it back into place. And it was incredibly painful. And we ended up having to transfer her to hospital for further care and assessment because she had managed to lock her jaw open by widening it excessively. So here's your maxillary fractures. These are your Le Fort fractures. The reason why they're called Le Forts is because a French physician had identified that from maxillofacial trauma, there were 3 very common, very consistent types of facial fractures. This is from significant blunt force trauma. In the old days, this was from military action. Nowadays, this is from motor vehicle collisions, falls, and assaults. This will often be presented with profound facial swelling, instability of the bones, and you'll have often a elongated appearance to the patient's face. Some people have incorrectly and inappropriately characterized this as horse face, but that's where it happens because you have a lack of connection here, and the bone will drop down. Your tissues in your face are fairly elastic, and then they'll drop down with it because, of course, here, this is providing support and structure, and especially here is a great example of Fort type 3. This is where you have a disconnection between the cranial vault and the anterior aspect of all of the bones in the skull. So Le Fort 1 fracture, this is just essentially the roof of your mouth has now come dislodged. Le Fort 2, this is that more classical pyramidal fracture. So it involves up along here, translates along to the top of the head. The entire nose and lower portion of the face have disassociated themselves, and it's usually fairly visually significant. And of course, in Le Fort 3, this is where you have a complete separation of the anterior portion of the face to the cranium. You can also have orbital fractures. Patients that have suffered this often complain of double vision or diplopia. They'll often have a loss of sensation above our eyebrows. You also have inferior orbital fractures. These are fairly common, and these can cause a loss of upward gaze, especially if you have the fractured material impinging on your ocular musculature or even the eye itself. Now, if you just bear with me for just a few seconds, let me check to see if we have that file that I wanted. Just give me one momento. By the way, any questions so far? It's almost 11 o'clock. Actually, you know what? It's 11 o'clock. We might as well take a 5-minute break, and then let's reconvene. Go for some coffee, some washroom, and we'll be right back at it in 5 minutes. Now, let's take a look here and see if we can see any fractures in the CT scan. Once you guys take a few seconds to look at it, tell me what you think. So here, and definitely here. So here we have a depressed skull fracture. Here we have a fractured orbit. So you can see the superior element has been fractured. Here you can also, it's a little hard to see on probably your screen, but here you'll be able to visualize fractures to the vomer in several spots. Now, it's probably almost impossible to see on your screen, but you can see there's a couple of pieces of teeth here that have been chipped off, and that should probably cover it for that CT scan. So obviously not the worst, but good example of a orbital fracture on a patient. What style of fracture do you think that one is?
The Lefort 2?
Correct. And here's just another example of it on a human being, and you can see where that fracture is and how there's no longer connection or communication with the cranial vault. So it's physically separated itself. So, oh, here is a, there we go. So let's zoom out a little bit here. So yeah, here we can see, you can tell this individual, and while you can't see it on this side, it is still there. This person is suffering from a Lefort type 3. So this entire plate is no longer physically attached to the cranial vault. So there's just a couple of quick examples of Leforts. Now we can get back into our other fractures. So zygomatic fractures, your cheekbone has been fractured. Generally, this is caused by trauma in a motor vehicle collision or by an assault. Patient's face may appear to be a bit flattened on one side. They likely, due to some nerve damage, will have a loss of sensation. And once again, your gaze will often be fairly significantly affected. Now, one thing we should always note is if we have fractures to the skull, fractures to the face, fractures to orbital fractures, should we consider that these patients may benefit from management with cervical spine immobilization? I would say yes. If they have enough blunt force to cause a fracture, then absolutely, you should consider, because remember, your axis and atlas, that is not a lot of tissue, not a lot of bone rather, that is supporting. So yeah, that can very easily fracture. Now, Well, do I need you to be able to tell the difference between a Lafort 1, 2, or 3 on an ambulance as an EMR? No, it's not going to really dramatically affect your treatment. I do need you to know that something has gone wrong and they now are suffering from crunchy head disease. And once you recognize crunchy head disease, we can treat appropriately in a facility. But just note, they suffer from crunchy head disease. Now,
Is that acceptable on a PCR?
nope, no, you cannot use crunchy head disease on a PCR. And I'm actually infamous for years. I would use OPS secondary to TMB. Any guesses? So if you guys have ever heard of Dr. Brian Bledsoe, he wrote the Essentials of Paramedic Care, Volume 1, 2, and 3 Canadian edition. And he and my dad were ambulance partners, and Brian was infamous. And I decided as a homage to do it as well, do OPS secondary to TMB, which stood for Old Person Syndrome secondary to too many birthdays. I would also utilize, Patricia was unhappy about that. I would also often use FDGB for patient fall down, go boom. Those are the two I would often use. I got away with that for years. I don't do that anymore. I'm now a much more professional practitioner, but back then I used to have a little bit of fun. But don't do what I did. It's very inappropriate, unprofessional. Remember, these are legal documents. Lawyers should have a field day. So I stopped doing that. So anytime we have significant facial injuries, we should consider protecting the spine. So we want to make sure that we assess for needing our collar applications. If they are fully alert, orientated, and conscious, follow your appropriate spinal clearance algorithm in your clinical guidelines. Make sure the airway is open and you have treated it appropriately. Make sure that there is no obvious bleeding in the airway. If there is, prepare to suction. Do positioning if needed. Consider if they are unconscious or semi-conscious. Outside of Yukon, you would use a nasopharyngeal airway in certain circumstances. However, if I have a nasal fracture or a potential basilar skull fracture or serious maxillofacial trauma, would I use it? No, absolutely not. You would, however, still consider using an oropharyngeal airway because we won't necessarily be able to manually manage an airway for the duration of our care. Now, make sure you are treating the facial lacerations and avulsions and any other soft tissue injuries just as you would any other. Just remember, if you are palpating and you feel crepitation under that injury site, don't push any harder. Please stop doing that and just treat it as you would normally and appropriately. Ecchymosis, we already know that's code for bruising, usually fairly notable bruising. Make sure that if you have an impaled object in the face, you leave it in place unless it poses a threat to your airway, in which case use discretion and remove if you feel that it is appropriate. Now, when you are removing an object from the cheek, the lecture notes remind me to mention to you that you be so kind as to please remove it in the same direction it entered. You can consider packing the inside of the cheek with sterile gauze and apply a counter pressure with the dressing bandage on the other side if you've removed that impaled object, because we want to prevent significant blood flow into the oropharynx, which would lead to an airway compromise. Generally, we are very careful putting things in the mouth, but if this is something that can help staunch blood flow and prevent blood from entering the airway, we should definitely consider doing it as appropriately. Now, make sure you assess the patient for hypovolemic shock in these situations. If you have significant bruising, you can consider using a cold compress or a cold pack and apply it to the patient, especially if it's around the eye. That can help control serious swelling. Do not apply anything directly over the eye. Do not apply it you don't want the vicus humor to be frozen. When you have an unconscious patient, make sure you have assessed around the neck and arms for any medical alert bracelets. Try to determine when the injury has occurred. Don't forget to do your sample. Remember, every patient gets that. Now, eye injuries. According to here, over 100,000 occur annually in Canada. That is a statistically significant portion of our population. This is generally caused by blunt force trauma, penetrating, or burns. So, for example, if I'm working with Rick in the Fleet Garage in Carcross, and I'm trying to do some work on that stretcher, and I got my angle grinder, hunk of metal flies into my eye. You know what? That's my fault. Why? Did I wear eye protection? Did I have my proper goggles on? Probably not. So, eyes often are not appropriately protected. A lot of people have this erroneous belief that they'll be fine and they can just look away. That's not how things work. And when it comes to eye injuries, if you have serious damage to the eye, like, for example, a laceration, this requires significant surgical involvement from a trained surgeon. This is not something we're going to be doing in the field. What we will do, however, is if we have serious eye injuries, we will place something over the eye. We should also consider covering the other eye. Now, normally, we would not like to remove someone's visual acuity. However, if I have eye damage on one eye, but my other eye is still open, if this eye goes to turn to look somewhere, this eye will still move to track whatever your one eye is looking at. So you can cause significant damage if we only cover one eye. Please make sure that you do a moist, sterile dressing directly over the eye, followed by a second dry, sterile dressing over top. Tape it into place. Do this bilaterally. Make sure you have vocalized to the patient what you're doing, why you're doing it, and then once you've taken away their visual acuity, it is incumbent responsibility upon you as a practitioner to continue to provide verbal diarrhea so the patient is aware of what's going on, what's happening, where you're taking them, because losing your sense of sight is a very anxiety-inducing situation, and we have to recognize this. If you have an impaled object in the eye, do not, under any circumstances, move it. You will stabilize it if needed. So, for example, if I have a pen and I've jabbed the pen into my eyeball, please do your best to stabilize it. One of the things I've done in the past is where I've taken a cup and I've placed that cup over top of the object and I tape the cup into place. Use it like a styrofoam cup or one of those standard coffee cups, the little, what's over here? What are they made out of anyway? Some sort of paper. You know what I'm talking about. Use that to stabilize if needed. You can have retinal detachment. This can be caused by blunt force trauma to the back of the head. This cut leads to a patient seeing what they think are light specks or, quote, floaters in the eye. This also is an emergency and requires immediate medical treatment. Orbital fractures, so fragment of bones can entrap the muscles. These can cause issues with ocular movement. This requires prompt transport. You can also have hypthemia. This is the bleeding into the anterior portion of the eye that can obscure vision. That looks quite bad. You can also have, so here, going back to your orbit, I think we all know what that is. This is part of why I'm not a fisher. I actually traded someone like this, and to this day, it gives me the heebie-jeebies. Like, no, thank you. No, thank you. Impaled objects in the eye terrify me, inordinately so. So remember, we're not taking that out. We're letting the professionals do that. We're letting the surgical team deal with that. We're not going to remove it, even if they really want to. Has to be removed by a physician. Do your best to stabilize it. Do your best to limit eye movement. Here is an example of a chemical burn, and you can see that the eye has been occluded with a white, cloudy material. This is likely caused by significant chemical burns. Make sure that in this
book
case,
it says a knife blade.
Here? Is that what that is?
Says
Sure.
439 is the page.
Oh, now I can see the blade. Okay, yes, now I see it. Now I see it. So in this case, your aqueous humor has, okay, now I see what's going on. So your aqueous humor has been exposed to light, and this was causing this cloudy, milky, and the sclera is no longer where it should be. So there we go. So now we have blunt eye injuries. This is where you have significant blunt force traumas, and you can have your orbital blowouts. Here's a good example. I've had protruding eyes before. Thankfully, only happened once. Retinal detachments. Here's your hypthemia. This is where you see blood filling the lower chamber, and it'll continue to fill up and eventually completely occlude the person's vision. Chemical burns. Make sure you are flushing these patients for a considerable amount of time, no less than 20 minutes. Make sure you use a sterile water or sterile saline solution. Your sterile water bottles have a blue top. Your sterile saline bottles have an orange top. Make sure you continue to flush. Do the best you can for these people. So here we have thermal burns. So this is generally caused by being too close to heat. This can happen in a structure fire. The eyelids frequently are closed, trying to prevent the eye from being damaged. So the eyelid may have extensive burns. The eyeball doesn't always. That being said, it can happen. You can also have infrared burns. This can be from people that have made the error of trying to stare at a solar eclipse light. In fact, if I remember correctly, a few years back, there was this marketing scheme where they're like, here, take this cardboard fold out of this magazine and these little slits, and you look through it, and it'll magically protect you. It certainly did not. And there was quite a few people that had burns caused by that. For these patients, irrigation may or may not have, for rather the solar eclipse lights, irrigation may not be the solution, but still you should cover regardless, prevent any further damage. Now, if you have vision loss, it doesn't improve. If you have double vision that we can't explain, if you have severe eye pain or any of these situations, do you think you should take this person to the hospital? I would say yes, yes, you should. So make sure that when we're looking at eye injuries, just because they have an injury doesn't mean a medical circumstance hasn't occurred. So try to do some detective work, see if you can figure out what's causing it, how long has this been going on for, when did it start, do they have any additional visual disturbances, do they have are they seeing colors, do they see bright flashes of light, double vision. Generally, this is an extraocular muscle injury with your visual loss. This can indicate damage to the globe or the optic nerve. Foreign body sensation. Generally, this is indicating a superficial injury to the cornea. So, for example, I have a fleck of dust in my eye, or let's say I'm out there with a saw and I'm cutting wood and something gets into my eye. You'll often have that foreign body sensation, that itching, scratchy pain to the eye. Make sure you evaluate all of these structures, take note of where they are, and make sure that you note any swelling, bruising around the eye, laceration, swelling, tenderness. Look at the eyelid itself, see if you can see any structural damage, especially if it's a patient that's been in a structure fire. They may have closed their eyes, trying to protect their eyes. Make sure when you use your pen light and you're doing your visual inspection, note the pupil size, shape, how it reacts to light. So if I flash a light in this eye, I should also see this eye react. Not much, but I should still be able to note it reacts. Make sure you note that. Observe the globes. Look for anything that doesn't look normal. So if I have, for example, a patient who I look at their eye, and the first thing I note is it's very, very yellow, what do I think might be going on?
Jaundice.
Yeah, absolutely, jaundice. If I see it fairly red, what's the most likely cause? Now, let me give you an example of what I mean by red. So this one.
So that would be like a hemorrhage of the vasculature in the eyes.
Yeah, this is a bit of petechial hemorrhaging, not overly terrifying. How about this one? So yeah, this is a fairly large hemorrhage within the eye. The patient will often complain of feeling pressure, and they'll often complain of feeling like their vision is becoming blurred and pressure being any more examples I want to show you. There we go. This will be, I promise you, the last one I will show you. Here's a very profound subconjunctival hematoma caused by blunt force trauma. So there you go. And you can see the ecchymosis. You can see some of the blood has begun to pool under the eyelid and is causing ecchymosis and bruising around underneath the eye as well. So fairly significant damage. And the fact that it is so profoundly dilated would imply that there's likely optic nerve damage in this case because this patient did not have a drug overdose. So, and while they're still alive, people like this, if you're alive, tells me either you have a drug overdose or you are in cardiac arrest because your pupils are dilated. In this case, because they're still conscious and alert and talking, this indicates significant optic nerve damage. So, visual acuity, make sure shine a light in this side, shine a light in this side. When you do it twice, once to visualize that eye, the second time when you do it, look at the other eye, note to see if it has moved. Once again, do the same here. Once I look at the eye, I note it. I do my second time, make sure this eye works correctly as well. And I do the, okay, follow my pen light with your eyes. Don't move your head up, down, side, side. Make sure you note both eyes are moving appropriately and document your findings. So if I have, for example, my grinder example, I'm helping Rick with something, hunk of metal flies into my eye, and I have eye damage, unlikely to kill me. Still requires treatment by a physician or ophthalmologist because this can be debilitating and can cause permanent lifelong impairment on a patient. Oh, excuse me, not the best breakfast this morning. So, eyelid injuries, often we are going to be treating with gauze, prevent bleeding into the eye, gentle patching, and just inform the hospital. So injuries to your globe. This is best treated in the ER. We will never exert any pressure or manipulate this in any way. The rationale behind this is we can cause catastrophic damage. I've had patients injured like this where they were still able to see, and you can see the eye trying to turn. I say, please stop, and then I will cover it with gauze because I don't want their eye to get any additional damage. Remember, moist, sterile dressings. We don't want the eye to dry out. A dry gauze applied directly to the eye, it is not a comfortable experience. It will cause irritation, it will cause pain, it will cause the patient to move it more. Please, 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 please make sure you are covering it with moistened, sterile dressings. Please feel free to, if possible, cover the injured eye with a, they say here in the textbook, a metal shield. I would say the cup technique that I was mentioning before would be perfectly appropriate. You should strongly consider utilizing spinal motion restriction, such as your collar. And while these injuries can be visually very disturbing, generally outcomes are fairly good. These can be surgically repaired as long as we do a good job of appropriate stabilization and treatment. Now, getting back into ultraviolet lights. Like I said, unlikely that flushing will make any difference, but we still want to protect it, prevent any further aggravation by additional bright lights. So once again, your sterile, moist pads, and then they say supine, position of comfort. Whatever the patient says I want, that's what they're going to get. Alrighty, so any questions so far? Now here it says if you have a chemical burn, irrigate for 5 minutes, or strong acid or alcohol, irrigate for 20 minutes. You know what? You should irrigate for 20 minutes across the board. The extra irrigation isn't likely to make things worse, but it may likely make things better. So I would say continue your irrigation as appropriate until you either A, exhaust the fluid supply you have on the ambulance, or you have reached a higher level of care to let them handle it. Does anyone here remember me ever describing the nasal cannula method I like to use for the eyes? So Cody's nodding. Do you know what he's talking about? So yeah, I will take a nasal cannula, I will tape it here to the bridge of the nose. Each little spigot on the nasal cannula is aimed towards an eye, and because if I were to take a saline solution, one of the big 500 mils, crack open the top, dump it on the eye. Okay, that was a second. Didn't even need a minute. Just 1 second, it's over. It's gone. It's done. That's totally pointless. So what I like to do is I will take the nasal cannula, and if I have IV tubing and IV bag in the ambulance, there's no harm in spiking that bag, connect the tubing to the nasal cannula, and then running that fluid through, so it's giving a nice, constant rate of irrigation. Otherwise, you will rapidly exhaust your supplies. Now, if you don't have access to the IV bag or IV tubing on your ambulance, you can still use that nasal cannula, and you can put a little hole in the top of your bottle, connect the tubing to it, and then you can still have that fluid move into the tubing and still irrigate. And that way you are, instead of having all your fluid administered at once, you can have a more gentle flow rate, and you can still obtain a level of irrigation for 20 minutes, even with limited fluid supplies. Now, use as much solution as you can. Be gentle, don't force it. So you're not going to be taking the saline preloads and spraying it into someone's eye. That will accomplish virtually nothing. If anything, what I would be concerned about is you may accidentally, with pressure, be forcing some of that chemical in behind the eye, but now I can no longer get rid of it, and that can cause significant damage. So the other option is in your obstetrical kit. In the ambulance, every ambulance has an obstetrical kit. There is a bulb syringe. And yes, Patricia's modeling what it looks like. I'll just quickly show you what it looks like here. Here, bulby syringe. There we go. So here's what the bulb syringe looks like. If you don't have access to the IV tubing, or you can't make it work and it's frustrating you and you just like, I need something, you can feel free to use the bulb syringe. It does fairly low pressure. It helps you do good stewardship of the fluid you have access to. So this will, again, better than dumping the whole bottle at once, you can use this multiple fills over a period of time. So this will help spread out the time you have that fluid for. So any questions there so far? No? Okay, great. So the nasal catheter method, this is the one I use probably the most, because I like to use my supplies, because I know my supplies are clean and I can control it a bit better. You can definitely, in certain circumstances, consider using a shower, especially if you have significant amount of fluid to remove. You can do the bottle method here. The issue here is that it's very easy to rapidly burn through your supplies, especially if you're doing it during transport. One single bump, half that fluid's gone. 2 bumps, all your fluid's gone. So that's definitely less than ideal. There's another option with the basin. The issue I have with the basin is all the other methods, the fluid hits the eye, moves whatever chemical is in contact away from the eye. The basin, whatever's there, you're just keeping it there. So you just, every time you dunk someone in there, you're just re-exposing them. So I do not advocate for the basin methodology in any way, shape, or form. So my preferred methodology is this. And sometimes in certain circumstances, I have been known to literally throw someone into a shower just because of some of the chemical exposure that they have received. Make sure you transport, continue irrigation as much as possible. And just lastly, reminder, don't remove anything in there. Also, one thing, I'm glad it's on here because I totally forgot to mention this, find out if the patient has contacts and consider having the patient remove them situationally dependently. There we go. So here's how to do a contact lens removal. This is not something we do as practitioners. We let the patient do it themselves. We don't want to be accidentally causing more damage. There is a procedure. We're going to talk to Ryan Susi later this week to get some guidance on whether or not this will be something the EMR can do or not. So that means in the meantime, we're not going to spend any more time on this. Now, management of eye injuries. Never pull anything out. So here you can actually see, if you look under the bandaging, you can see a cup is there. So the practitioner has put a hole in the cup and then slid the cup over top of the impaled object. And then they're now using Kerlix or roller gauze to secure that cup to the patient's head, providing stabilization to the eye. Now, the problem here is if that person moves their eye at all, you have that impaled object that cannot move in any way, shape, or form, and that will definitely cause additional eye damage. So make sure the patient is aware that they cannot, under any circumstances, move their eye. It will cause more damage. So let's move on to ear injuries. So you can have avulsions. In fact, if I remember correctly, the very first example of an avulsion in our textbook is an avulsion to the tragus of the ear, if I'm not mistaken. That's way back, and I think it was a chapter 5 or 6. It was way, way back in week 1, and that was our first visual example that they utilized. Definitely, you can have permanent disfigurement from this. You want to know if it was caused by blunt or penetrating trauma. Your pinna, this is up here in the ear. It has an inherently poor blood supply, heals poorly. This is part of why we want to make sure in the wintertime we have it covered appropriately, because frostbite will happen on the ear very easily because it has a fairly low blood supply there. So we want to be very careful there. Healing infections can rapidly cause the loss of an entire ear. So any injury, regardless of what it is, BSI, PPE, wear your gloves, wet and sticky, not yours, don't touch it. Assess your mechanism of injury. Do your airway, breathing, circulation. Consider potential for spinal stabilization. So we want to determine what caused the ear damage. For example, someone ripped your earring out of your ear. Okay, probably don't need a C-spine stabilization. Or, for example, you were in a high-velocity motor vehicle accident and your face slammed into the side of the window and the glass shattered and it sliced off your ear. Okay, maybe I should consider doing C-spine protocol on you. So make sure you do situationally dependent, assess the need for it. They say assessment can be very difficult in the field. Well, that is partly true because if you have a ruptured eardrum, for example, your patient may not be able to hear you. You can have profound loss of hearing. If you have blood drainage from the ear, do that quick test with the gauze, see if there's any cerebrospinal fluid pouring out. Place gauze over top. Make sure you are explaining to the patient what you're doing if the other ear is undamaged and still able to hear. That being said, in certain circumstances, you may even need to write down what you're doing. For example, for Randy this morning, I had written down for him a note saying, "This is where I left off. Please continue from there." So when we talk about managing, we want to, if there is a avulsion, we want to try to put it back and ensure that there's still some blood flow to that part. It is possible in certain circumstances for the avulsed part to be reimplanted. We don't determine whether or not it's going to be successful. We let the surgeons do that. We ensure we give that patient the best possible chance for a successful outcome, so we treat it appropriately. So if it's a complete avulsion, as I heard Randy explaining yesterday, make sure you have retrieved the part, treat it like you would as any other amputated part, wrap it in moist, sterile dressings, place that into a baggie, and then place that in amongst either ice or cold packs or what have you, making sure you don't have fluid soaking the amputated part. Make sure you do your CSF test where I take that 4x4, place it over the ear. Don't stop the flow, because if it's leaking out, we don't want to cause a pressure buildup. And then, of course, look for signs and symptoms of a skull fracture and treat as appropriately. So, impaled objects, yes, this can happen. Stabilize and cover the ear as appropriately. Do your best to do a additional assessment. Consider C-spine precautions as well. Do your best to stabilize the object. Feel free to use the cup method here as well. Make sure you are covering the ear as well to prevent any movement. Make sure you direct the patient. Please don't turn your head, especially if you have them immobilized. That can cause additional damage as well. Now, getting back onto our topic of oral and dental injuries. I'm a great example for a dental injury because I had some fractured teeth from my accident on the motorcycle. If you have missing teeth, please attempt to identify them, bring them with you. You should consider potential airway compromise. There's a likelihood that if they have missing teeth, they may have lacerations to the tongue and cheek. This can cause notable bleeding within the upper airway. So again, make sure you have your suction equipment ready, handy to be utilized. The other problem is if you have a lot of bleeding in the mouth and the patient is swallowing it, which they will often do, the issue is this can irritate the gastric lining, which of course, as we know, when the stomach's unhappy with something in it, it wants to go bleh, which can just aggravate our problem and cause additional airway compromise. So treat appropriately, suction as needed. There we go. So like I said, fracture of most teeth, you want to identify them, collect them, bring them with you. I have seen successful reimplantations occur. These often occur following an assault. Make sure that you have ensured the scene is safe and that there is no one around that can cause you to be injured. I think that pretty much covers it for that slide. Again, just like with any other injury pattern, do your proper PPE, body substance isolation. Make sure that there's no scene safety threats. Do your ABCs as needed. Ensure you have both your handheld and your battery-powered suction from the ambulance with you. In these cases, be prepared to suction as needed and follow your spinal clearance protocol. Just like anywhere else in the body, leave it in place and stabilize unless it is directly interfering with your ability to manage the airway. Then remember, remove it in the direction it came in, and then on both the interior and exterior aspects of this injury, make sure you are applying gauze to prevent bleeding into the oropharynx, causing an airway compromise. Now, most tooth, they can be successfully reimplanted depending on the time frame. Don't touch the bottom of the root of the tooth. Feel free to gently rinse it with sterile saline or water. Some people have used milk. That's perfectly fine. Inappropriate things to utilize would be, for example, mouthwash. No, please, please, no, don't do that. That will just destroy the structures inside that tooth, and it will no longer be reimplantable. So anytime we have significant injuries to the anterior portion of the neck, we are very, very concerned for one, possibility of cervical spine injury and airway compromise. Motor vehicle collisions are often a cause of direct trauma to the neck. So are hangings, gunshot wounds, stabbings, impaled objects, and let's not forget our lovely favorite, assault. These can cause profound neck damage. One I had not too long ago was a fellow was on a, what are those silly bikes called? Dirt bike. That's it, yep, they're on dirt bike. He's ripping along on his little dirt bike and illegally trespassing in a farmer's field, comes through a grove of trees and clunk! Barbed wire fence. And the barbed wire ripped out a good portion of the anterior tissue in the throat. So that was a fairly challenging one to deal with. Patient survived, but still, it was very challenging. So injuries to the anterior portion of the neck. They can be survivable as long as we are treating as appropriately. So make sure you consider cervical spine involvement. If for whatever reason you are going to consider immobilizing these individuals with a C-collar, I would make the argument that the collar would not be an appropriate device to be applied here. This is where our critical thinking skills can come into effect, and we should consider doing something like blanket rolls that can go around the neck, along the side, and that can help provide support because a collar application here would be very inappropriate because that would be directly impinging upon these impaled objects. Now, obviously, you can visualize the structures here. We can assume there is likely involvement of internal vasculature. There is likely involvement of the esophagus and or trachea. So these patients are can be very difficult to manage. Air embolism, as it correctly mentions here, so if air is introduced into the vasculature, it can lodge itself in the brain, it can lodge itself in pulmonary circulation, and this emboli can still kill you. And then granted, we used to teach people, oh yeah, it's at least 10 cc's of air before it's going to kill you. Not necessarily. And you can have fairly significant air emboli here that can lead to death. So, moving right along, injuries to the larynx, trachea, and esophagus. I think here especially fairly obvious injury pattern to the trachea. These can be very life-threatening. Supporting structures can be catastrophically damaged. Make sure you are doing your assessments, monitor your ABCs, reassess on a regular basis. An esophagus perforation, unlikely to be immediately life-threatening. The airway compromise will likely be the life-threatening consideration. This will be something that will obviously affect them in the hospital, not likely to be an immediate effect in the back of an ambulance. That being said, if they begin to aspirate blood into the trachea, this is a huge, huge concern. These patients will likely benefit from endotracheal intubation or from a surgical airway that can be inserted by our critical care team. Now, assessment of neck injuries, make sure, as always, you assess your mechanism of injury, you have your BSI or your PPE in place, always assess for scene safety. For your cervical spine stabilization, we do not want you doing a head tilt chin lift. We do not want you to manipulate the jawline. Or rephrase, don't want you to manipulate the neck. You can manipulate the jaw in certain circumstances, knowing that the muscles are often interacting with other structures in the neck. So make sure you are treating appropriately. Now, the most life-threatening ones will be your airway compromise and exsanguinating hemorrhage. You want to, whenever possible, try to use an occlusive dressing. I have seen practitioners try to use ECG electrodes to seal a small hole. I've never seen it actually work. You want to also apply your manual bulky dressings over the neck with these patients. There's anything else I want to mention. Now, when they say loosely wrapped roller gauze, that's definitely a very last resort that I'm not overly comfortable with. Tape is your friend. Lots of tape, just like Randy was saying yesterday. Tape will fix everything. No, it won't, but you'll try anyway. Do not use circumferential wrap bandage around the neck. This will be unlikely to be a successful treatment. Now, you may often notice a significant amount of bruising or redness around the neck. You will often have palpable tenderness. A patient may have notable pain. They may complain of an inability to swallow. They may complain of feeling like there's a frog in their throat or there's some sort of obstruction in their throat. Make sure you do your best to manage these patients, treat for shock. Try to do your best to call for an ALS unit or have your RN establish vascular access. Give me one second to reply to a quick message. And then, of course, your surgical airways, ETs may not be successful, and you may need ALS to do this. So, head injuries, about 50,000 a year in Canada. About half of your traumatic deaths are caused by these traumatic head injuries. Now, obviously, if you have intracranial pressure and that begins to impede on the brain and it's going to start to herniate that foramen magnum, obviously you will have respiratory compromise, you'll have cardiovascular compromise, and that can rapidly lead to death. It is true that MVCs are the most common mechanism, but the number 2 in Canada is unfortunately assaults, followed very closely by falls by the elderly, because remember, their vasculature is a bit compromised. Damage to it can cause ruptures fairly easily, and that can lead to intracranial hemorrhage and death. Now, obviously, the majority of ones will be closed head injuries. The skull is a fairly strong structure. It does resist high energy kinetic impacts fairly well from a blunt object. Your frontal bones are most susceptible to skull fractures. From the picture we showed you before, that's pretty obvious. The brain generally isn't exposed to the environment from skull fractures. From a closed one, you can have open skull fractures where the brain is visible. The thing about skull fractures, about closed head injuries is, remember, it's not just the impact to one portion of the head, it's the fact that the brain, if I get impacted here, bounces on that side, now bounces on the other side, have that contra-coup injury. So you can have damage to both sides of the brain, even if only one part of the skull was impacted. Just be prepared for seeing additional pathologies on these patients. Now, you can have situations where the overlying tissue from a skull fracture looks like it's intact, but you can still have the underlying skull significantly fractured. You can have bony fragments that have been driven through the meninges into the brain, causing brain damage. And so just because you have what appears to be superficially nothing fairly obvious doesn't mean you don't have interior damage that you cannot visualize. This is part of why we need transport to definitive care, because we don't have X-ray vision. Now, moving on to open skull fractures. Clearly, we have a high risk of infection. The brain has the blood-brain barrier. The brain has the meninges protecting it. The brain has the skull protecting it. Because the brain is sensitive, very sensitive. If we have an open skull fracture, now we have direct pathway for nasty things to go to the brain. We don't want that. Now, the slides talk about how gunshot wounds are the most common mechanism of injury. Absolutely true. High velocity motor vehicle accidents, or people that are on motorcycles without helmets are obviously fairly high up the continuum for open head injuries. The mortality rate is very high often because if you have significant structural damage to the brain, that'll cause impairment, and also because infection will kill you. And a lot of the antibiotics and medications we give are unable to go past the blood-brain barrier, and this means that if you have an infection, it's more difficult for us to treat it. So a lot of issues there. And with survivors, you most often have fairly significantly decreased quality of life. I've treated patients in transfers who had been traumatically injured when they were a kid, and one had locked-in syndrome, so cognitively he was still there, but he was unable to communicate in any other way other than being able to slightly grip your fingers with 2 fingers. That's all he could do, nothing else. And for years, people actually thought he was totally brain dead, and they were just keeping him in long-term care. And one day, out of boredom, I decided to do a little test and see, squeeze my hand if you can hear me, and I once for yes, twice for no, and that's when, to my absolute horror, we discovered he was still cognitive, at least to a point. Knew who he was, knew where he was, knew what was going on, and that was terrifying because no one had thought he was cognitive due to locked-in syndrome. So, moving right along, scalp lacerations. You have highly vascular tissue, can lead to significant blood loss very quickly. It's often very graphic. With kids, you run the risk of dealing with a hypovolemic shock. Now, with adults, this is often we need a significantly larger amount of an insult to cause exsanguination. That being said, here in the Yukon, we actually had a fellow who exsanguinated almost 2.5 liters from a scalp laceration. So it can still happen. Remember, apply pressure as long as no crepitation and as long as you don't have any deformity to the underlying structures. We want to stop that bleeding. Definitely make sure you have, whenever possible, irrigated it to clean it out if you don't want to have any infection occurring. There are several different skull fractures. You have a linear skull fracture. This is where along the suture line, you have a fracture, and it can often extend out from the suture line in a linear fashion. Sometimes it's strictly along the suture line. Depressed skull fracture, I've already demonstrated this physically, not visually to you rather. Your basilar skull fracture, this is where here at the back to the base of the cranial vault, a fracture has occurred. This is what allows your cerebral spinal fluid to exit. So there's often communication between the auditory canal and the fracture for the basilar skull fracture. Taking the path of least resistance, it translates itself out there. Often, these basilar skull fractures can also extend forward and connect here with the nose. So sometimes you will have cerebral spinal fluid coming out of the nose. This is also why we are so terrified about putting anything into the nose like an NG tube, which I have demonstrated to you before, how it can unfortunately wind its way into the brain, causing catastrophic damage. And of course, lastly is your classic open skull fracture, where now we have the skull broken and we have direct pathway into the cranial vault. Any questions so far? I will say depressed skull fractures, these are generally from a high energy direct blunt force trauma to a small. You know what? It's noon anyway. Let's take a break now for lunch. See you back in 45 minutes. I believe we had just finished talking about depressed skull fractures, and we were just moving on to the basilar skull fracture. So generally, high energy impact from the head. This can also be from motor vehicle accidents, usually a extension from a linear fracture. So if you look over here, this can often extend down, crack along, and can enter down here, and that can lead to the basilar skull fracture. Not always, but often enough. So, Cody, because I feel like picking on you again, what would be the visual signs that we as a practitioner can see that would indicate the patient may have a basilar skull fracture?
Like bruising around the ear.
Yep. What's the other name for that?
Ecchymosis. How do you?
Close. So back here. Oh, wrong way. There we go. So back here, this would be your battle sign, and over here would be your raccoon's eyes or your periorbital ecchymosis. Well, what is another indication that we may have a basilar skull fracture? Yes, Patricia?
Leaking CSF from your nose or your ears.
Congratulations, Patricia gets the textbook answer. Excellent. So, and lastly, of course, let's now quickly talk about open skull fractures. Obviously, visually, these should be fairly easy to determine. You will see a hole into the cranial cavity. You'll be able to see part of the brain. and this patient often has been subjected to profound traumatic force. More often than not, these patients have been exposed to multi-system trauma. The brain can be exposed to the environment, and obviously this can lead to a high mortality rate. And it's not actually the brain exposure per se that causes the fatality. It is the infection that occurs later on that leads to a negative outcome. So here's some more discussion. 80% of all fractures are linears. About half of them are about here. Often you don't have any blatantly obvious signs, and as long as it's not an extensive one, generally relatively benign. The, of course, concern is that if there's a scalp laceration, communicates with that fracture, you can have a direct pathway for things to enter. The depressed skull fracture. The classic example is Randy thinks I'm a terrible instructor and I'm stealing his thunder and he wants me to shut up and bunks me in the head with a baseball bat. Another classic example, pretending you're Superman flying into a post head first without a helmet. Your frontal parietal regions are most susceptible. Now, frontal, we have the sinus. So in the sinus, you have an exterior portion of the skull. You have your sinus, so this nice little pocket of air, and then you have the other bone, which is now forming your cranial vault. So you have, just like in a car, a bit of a crumple zone. And that's what saved me from having an open skull fracture, was that I had that crumple zone to absorb some of that kinetic energy. Also having my arm out and absorbing kinetic energy also helped as well. So they are relatively thin, absolutely correct. Some of the concerns is that if you have, let's say, that baseball bat, if I have that blunt force trauma, it has struck the outside of my skull. If we hit, let's say, a piece of gyprock, some of it on the other side burst off and fly out. If you have a piece of metal and it's been shot and it's bulletproof metal, sure, it won't go through, but on the other side of it, things can fly out. The skull is about the same. So if you have sufficient kinetic energy to cause a depressed skull fracture, you can have shards on the other side of it move outwards into the brain. You can also have those fragments from the depression forced down and into the brain cavity. You can have loss of consciousness. Remember your contra coupe injury. You can have cerebral edema caused by an insult to the brain. This can now cause the brain to begin to swell. And you can also have subdural hematomas, arachnoid hemorrhages, and severe intracranial pressure can rapidly occur. So make sure you do a proper assessment, get your baseline set of vitals, monitor these patients for respiratory changes and signs and symptoms consistent with intracranial pressure. Now, here are our basilar skull fractures. You can see here this reddening. This is the beginnings of battle signs. You can see here this shiny fluid on this patient's ear. This is some of your cerebral spinal fluid. Here is the fairly classical example of periorbital ecchymosis, aka raccoon eyes. And then down over here, you can see also the beginning, I would say in this case, looks more like a slightly resolved battle sign. I've seen it far more extreme than that. In fact, if you can give me just a few seconds. Oh yeah, that is definitely what we want to show you. This is what I've seen. Pretty obvious. They say it's often a late sign. You know what? I've seen it develop within 2 to 3 minutes of impact, so not necessarily always a late sign. Now, open skull fractures, I like this because it also shows some CT images. So there we go. So here you can see fairly profound open skull fracture, clear communication with the cranial vault and brain tissue. And here with the imaging, you can see how this damage has impacted the brain. You can tell some tissue has been insulted here. However, you can also tell there hasn't been any extreme cerebral herniation because the brain has now lots of room to swell up. That being said, I would expect this to be a potentially negative outcome. However, survivable provided that infection is mediated. So high infection rate, because remember, blood-brain barrier, really hard to get those antibiotics through, very high mortality rate. That being said, it is still perfectly survivable. So, brain damage. This can produce physical, intellectual, emotional, social changes. So in my case, I have difficulty with memory recall. I have difficulty with memory retention. Because one thing I never mentioned to you all was that I also had intracranial hemorrhage as well, caused from the injury. So this led to definite difficulty moderating my emotions. I find that I definitely wear my heart on the sleeve. I will cry at a drop of the hat when I never used to. I will definitely feel a lot more irritable than I ever used to, and very, very, very quickly progress on that continuum. And I feel so awful for my wife, because this happened the day after we got married. So I'm not the man she married, not mentally anyway, not the way I should be. So I feel really bad for her because of that brain injury. And for social changes, it definitely, I'm just speaking to you here because I have personal experience, so I can express to you how it affects the patient. I feel much more socially isolated. I have a inherent now unwillingness to want to socialize, because I am terrified of people reacting when I'm more emotional than I used to be, when I feel a little more, I feel very, very socially awkward now, more than I ever did before after the head injury, and I don't feel like I can really cope really well. So I have a very, very minor TBI. I've had patients who, as I've mentioned before, locked-in syndrome. So cognitively, they're still functional, but they're no longer able to outwardly express themselves. I have patients who have regressed to a state comparable to a toddler, even though they're a fully grown adult. And it's very profound how even a minor brain insult can cause profound changes going forward in life. Football players who have encountered multiple concussions often have significant memory impairment as they age. So it's not just traumatic head injuries from motor vehicle accidents, but it can be from repeated, repetitive concussions and other injury patterns. So anyway, your primary, this is what we refer to as when that actual injury has occurred, when the brain has slammed forward in the cranial vault into the skull, or had a skull depressed, or what have you. Physical damage has occurred from the impact. More often than not, the physical damage from the initial impact isn't what's going to cause lasting long-term impacts. Generally, not always, but generally. The secondary effects, I find, as a practitioner, are often far more catastrophic. So for example, I had a patient who, he was on his BMX, didn't have his helmet on, fell, struck his head, and our on-scene time was 3 minutes. We were flying with a speed and skill that was well beyond us. And the moment we got on scene, it was blatantly obvious this poor fellow had crunchy head disease. So this is back when we still had to do the full automobilization. We collared him, we boarded him, we threw him into the truck. Our on-scene time was 3 minutes. We were just flying. We raced over to the regional hospital. Here you go, bye, we're out of here. Go fix him, please. And a couple hours later, we get a call saying you have a facility transfer. The patient had not been appropriately treated, and the brain had begun to hemorrhage out of the cranial vault. And actually, I was wiping away some stuff from his nose because I thought that was snot, but because having been a practitioner on very busy services with very high trauma acuities for many, many years, I had been exposed to a lot of gray and white matter in my career. And as I wiped away tissue from his nose, I realized to my horror, it was not snot, it was brain tissue. And it was hemorrhaging out of his nose because the intracranial pressure had not been alleviated, the patient had not been treated appropriately, and the profound intracranial pressure forced the brain down out of the cranial vault and out through the remaining holes in the skull. So unfortunately, very negative outcome. the brain was catastrophically damaged, and the patient, I do not believe, is still around. So the initial injury, when we were on scene, we're orientated conscious, so the initial impact into concrete with the skull wasn't what caused permanent brain damage. It was the failure to recognize intracranial pressure, the failure to treat intracranial pressure, and the failure to get to definitive care in a reasonable amount of time that led to a negative outcome. So all the secondary effects, the brain swelling, bleeding around the brain, the increased pressure doing structural damage, bleeding, forcing the brain down through the foramen magnum through a period of several hours. That is what led to the lasting, permanent, irreversible damage. So generally your secondary effects are the ones that are worse. The most depressing part though is these are ones we can generally also mitigate with appropriate medical care at a surgical center. So continuing on with our traumatic brain injury. So this is where, when I remember these slides from last week, you struck the windshield, the brain, it impacts the skull, it bounces backwards, that's your coup, contra-coup injury pattern, very common, will cause cerebral edema. Cerebral edema, fancy word for excessive fluid in the tissues, causes swelling, cerebral vasodilation. The vasculature has increased in size. So not only do you now have an increase in fluid in the vasculature in the brain, but now you have that vasodilation, which allows more fluid to leak into interstitial spaces, which will again increase the amount of swelling we have, which will then lead to increased intracranial pressure, which will do more structural damage, which will cause more cerebral edema, which will cause more vasodilation, which will increase your ICP. You see this cascade effect of sadness and despair. This is why we want to recognize the injury pattern. We want to recognize this requires rapid transport, and we want to be able to do what we can to mitigate it with arguably hyperventilation, which we'll discuss in a few minutes. But I digress, for I'm getting ahead of myself. So I've already discussed how the accumulation of blood can lead to increase of pressure. So one of the things we need to know is our MAP, mean arterial pressure. Here we go, short little video, nothing too crazy. One momento, please. Go back just a couple of seconds.
So how do we calculate mean arterial pressure? Well, to do that, we have to remember this formula. So I would commit this to your memory. It says the mean arterial pressure is equal to the diastolic blood pressure, which is that bottom number, times 2, plus the systolic blood pressure, which is the top number, divided by 3. And to calculate your MAP, what you need to know is you need to know the person's blood pressure. And here our blood pressure is 102/70. So let's set our problem up and work it. Okay, so our diastolic is 70. So 70 times 2 equals 140. And then we're going to take 140 and add that to the systolic blood pressure. So 140 plus 102 equals 242. Then we're going to take 242 divided by 3. So 242 divided by 3 equals 80.6. Repeating. We're going to round that up. So our MAP is 81. And how do we interpret that? That is within normal limits. So our MAP is good. Okay, so that is how you calculate the mean arterial pressure. And don't forget to take that free quiz for some extra practice problems. Thank you.
There we go. So that's how you calculate MAP. Now, for UConn EMS, our Zoll X series and our Zoll monitors will automatically calculate MAP provided you're using an NIBP, non-invasive blood pressure, that's connected to the monitor. As an EMR, nothing stops you from hitting the NIBP button and it'll automatically do that calculation for you. That being said, most EMR ambulances, with the exception of Watson and Dawson, will only have the Zoll Zoll AED Plus, which obviously does not have a BP attachment. That being said, now you know the calculation. So we want a threshold of 6 millimeters mercury for a MAP. This means we're still having some cerebral perfusion. Goes too high, we have too high of intracranial pressure. Goes too low, we're no longer able to generate the appropriate amount of cerebral perfusion, which will cause an anoxic injury, lack of oxygenation to tissues, and the brain cells will begin to die. So anything below 60 for a MAP will lead to cerebral ischemia, and if left untreated for too long, can lead to permanent neurological impairment and death. Now, the body will generally respond to a decrease in cerebral perfusion by increasing arterial pressure. However, this will increase your intracranial pressure. Leads to a vicious cycle. Now, we as practitioners are unable to calculate your CPP. We cannot do that in the field. However, we can calculate MAP. So we can't calculate everything, but we can definitely calculate our MAP, which gives us an idea of what our cerebral perfusion pressure is. Now, cerebral herniation, I've already discussed this. This is when the brain is becoming forced into the cranial vault and down through the foramen magnum. You will have some fairly obvious signs and symptoms right from the get-go. So for example, you will have vomiting, headache, no kidding, altered mental status, seizures. Really ominous signs are where you have irregular respiration. So if we have that same Stokes respiration or Biot's respiration, we know we have catastrophic damage to the medulla oblongata. We have damage to our respiratory center, and we know without a doubt we have some form of intracranial pressure. Now, another one that is very concerning to us is if we have an unequal pupil. So one is 6, one is 2. That is terrifying. Or you have a non-reactive pupil. Now remember, before we make assumptions, ask the patient, have they had any eye surgery before? Have they had any eye damage before? If they're able to verbally respond, you might not know that it's a perfectly normal symptom for them. Without going into too much detail, because it's a story I'm reserving for later, I had a patient who, one, had a normal irregular pulse, normally hypertensive, and normally had one pupil dilated, one was a bit sluggish, and this individual would often pretend to be experiencing a CVA. And when you have hypertension plus the irregular heart rate plus the pupil changes, when you're a practitioner and you've never met this person before, it's terrifying because you think it's legit. And it turns out she was fake and she would just do it for fun. But anyway, I digress. That's a story for a later lecture. Now, continuing on. Now, there is a triad when it comes to cerebral intracranial pressure. I know Patricia probably knows it. It is called Cushing's triad. So does anyone here, aka Cody, because I know Patricia has the answer. Does anyone here know what what Cushing's is? So Cody, do you perhaps know it?
I recognize the name from when my fiance was in nursing school, but I don't know what it is.
Okay. That is A-okay. So Cushing's triad starts off with a widening in your pulse pressures, irregular respiratory rate, and you often have, like I said, profound hypertension. Let's see here, irregular respiratory rate, hypertension, widening pulse pressures. Oh geez, now I'm trying to remember now. Hypertension, widening pulse pressures, regular respiratory. Well, that is the three of them, isn't it? Yeah, no, that is it.
Bradycardia.
Oh yeah, bradycardia, right. So the brain will realize, and thank you for pointing that out, the brain will realize that something's wrong, and it realizes the pressures are way out of control. So it'll slow its heart rate down to try to mediate that intracranial pressure, but it'll realize, okay, I still need more pressure. I still am not getting enough perfusion to all of my tissues. So you have that increased hypertension, and then, like I said, it's a vicious cycle. So once you have that bradycardia with the respiratory changes and the widening pulse pressure, you have fairly easily able to assume that they have significant intracranial pressure. Body responds to a decrease in cerebral perfusion pressure by increasing your arterial pressure. But this, however, like we said, it increases your intracranial pressure. It's a vicious cycle, and you will have those blatantly obvious respiratory patterns. And let's see if I can call up this. So we did watch this once before. That being said, so here you can see abdominal breathing, and you can see how it's not a very regular, it's increasing in its rate, and now it's slowing down. And there we go, almost cessation, it stopped. Long stop. I like how on here you can see the SpO2 dropping. Now he starts to breathe again. That's a long pause. You can see it starts off slow, builds in rate. And you can see the oxygen sat has come up to 92. You can also see, now 94, and you can see the bradycardic. So this individual is exhibiting all of the signs and symptoms consistent with cerebral herniation. So that's a nice little visual example. So remember, the difference between deceribate and decorticate. Decorticate, and they bring the arms up to the chesties. And deceribate, they're doing this this odd posturing here. I had the misfortune of seeing both. Some of the symptoms early on before they progress to this stage, vomiting, headache, altered mental status, seizure activity. You'll have your Cushing's reflex. You'll have those irregular respirations, often comparable to Shane Stokes or Biot's. However, when you see posturing, you normally have fairly profound brain damage. So anyway, if you do a pain stimuli, the patient, if they are deceribate, they will, like I said, bring the arms up to their chest slowly, and you'll see them flex. You'll see the points of their toes extend. Their muscles will tension up. With a deceribate, remember, instead of the arms coming towards the core, they move away. So that's how you can have so the difference, deceribate to the core and decorticate to the core. Deceribate is away. That's how you can have the difference. Decorticate to the core, deceribate is away. So that's how you can tell the difference between the two posturings. For GCS, if you remember correctly from Randy's lecture, posturing, this is what they're referring to. So, a diffuse brain injury, this is something that affects the entire brain injury. So, it can cause by concussions, spinal cord damage. This can be caused by multiple different disease pathologies as well. Generally, these will resolve themselves. This would be from a, let's say, for example, a level 3 concussion. We can have brief retrograde amnesia or anterograde amnesia. Not to spend too much time here. Diffuse axonal injuries. So again, this is generally a more severe brain injury. This is where a stretching, tearing, shearing of nerve fibers has occurred, causing irreversible structural damage. This can be caused by high-speed rapid acceleration, deceleration forces. Severity depends on the degree of axonal damage. So you can have a mild one where the patient may have just some impairment with speech or memory. You can have more severe ones where they are unable to speak anymore. See, what else am I forgetting? No, that pretty much covers it. So with the focals, you can clearly see this on a CT scan. You'll see CT cerebral contusions, intracranial hemorrhages. Usually you'll see a fluid in the cavity. So what are some other examples? So a cerebral contusion is basically a fancy word for the brain tissue has been bruised and damaged in a fairly specific localized area. You can often have obvious neurological deficits from a cerebral contusion, such as prolonged confusion, loss of consciousness. These are fairly common in situations where significant deceleration has occurred. So for example, if we're in a motor vehicle accident, we're traveling along at 110 because no one goes only 100 in the Yukon, and you come to a sudden quick stop, this can often occur. So like I said, basically the brain tissue's been damaged. Similar mechanism of injury to concussions, and like I said, the brain tissue will begin to swell, and depending on the severity, we can go from just, because there is some room for the brain to swell, not much, but there is some. You may not necessarily have an ICP problem. However, if it's a significant injury, you can very rapidly move into a situation where you have intracranial pressure. So the problem with an intracranial hemorrhage is when there's no room in the skull for blood to accumulate. You have cerebrospinal fluid, you already have the brain taking up a lot of space, there is not a lot of room to maneuver. So once we have a bleed in here, this wants to fill up all the remaining space very rapidly, and once that happens, the brain only has one place to go, and that's down and out the foramen magnum. So structural damage can rapidly occur. So you can have an epidural hematoma. This is where blood is accumulating between the skull and the dura mater. Remember, the dura being the topmost layer. You can have a subedural hematoma. So this is beneath the dura mater, but in between the brain and the dura mater. You can have a intercerebral hemorrhage. So for example, it's occurring somewhere in brain tissue. And then of course there is the subarachnoid hemorrhage. Now, a epidural hematoma, about 1% of all head injuries have this. Not very common, generally caused by a physical blow to the head from blunt force trauma, often associated with a linear fracture, and often the patient will have a loss of consciousness with a brief lucid interval. So hold on, famous person, I'm thinking. The Taken guy. What's his name again?
Liam Neeson?
That's him. His wife died from an epidural hematoma. So she had that lucid interval where she fell, struck her head while skiing, got back up, was totally fine, A-OK for 1 hour. And then the lucid interval ended, and death rapidly occurred because they didn't have surgical intervention in time. Now, a subdural hematoma. So like you said, we have that fluid accumulating between the brain and the dura mater. This is outside of the brain, and this is a little more common, happens about 5% of the time. This is where you have strong deceleration forces. So there are veins that bridge the cerebral cortex, and they can rupture and lead to bleeding into the subdural space. Now this has an added benefit of it takes longer to hit because a venous bleed isn't as rapid as the arterial. There's also less pressure, so it takes a little bit longer for a venous bleed to do significant damage. That being said, it can still be an issue. You will often note slightly more focal neurological damage, such as slurred speech and some other interactions where the patient may think they're communicating with you, but they're not making any sense. Now, where is our Let's see here. So yeah, here's your epidural hematoma. Here's an example. So you have your fracture line directly over top of the meningeal artery. Blood now enters that space and begins to put direct pressure onto the brain. So often you'll have that lucid interval. You'll have a brief period of unconsciousness followed by they're conscious, they're awake, they're okay, and then they go back to being unconscious again. So then you'll have often those pupil changes. So they may be fixed on the side of the hematoma. And like I said, death if pressure is not immediately relieved. Here is an example of your subdural hematoma. So you can see here's the dura mater. So the skull hasn't been destroyed in this case. The skin is still intact, but underneath the dura mater and between that and the brain, we have this hematoma. Now, part of the problem with these situations is the dura mater doesn't really give a lot of flexing, tough sinuous material, just like the pericardial sac. The blood only has one way to go, and that's to compress the delicate structures of the brain. Now, the beauty of these is because they're venous bleeding, they're slower. The brain will usually compensate for a while before fairly obvious injuries have occurred. Now, intracerebral hemorrhage. Generally, these are very fatal, very rapid. My grandmother actually died from intracerebral hemorrhage. Now, yes, definitely can occur from injuries. However, in my experience, these are generally caused by an aneurysm or a existing defect where the vessels are not necessarily as strong as they should be. So your subarachnoid hemorrhage, and it's interesting, it doesn't have a picture, so let me go get you one. There, that will work overall very nicely too. So here we got two different ones. So here we have, here's your epidural, here's your intercerebral, here's your subdural, and here you have your subarachnoid down. And it's not necessarily going to be down here, but what's important is it's below the arachnoid mater, and this is where you can have this accumulation of blood, can cause fairly catastrophic damage. These patients generally have a fairly specific presentation. Here is another example of a subarachnoid hemorrhage. So here be a normal CT scan. Here you can see in these regions here, the pressure is exerting on the brain, so it's not aligned correctly. You can see the ventricular shifts, so you can see the ventricles in the brain have changed their shape because of the amount of pressure being exerted by the subarachnoid hemorrhage. So, like I said, these patients have a fairly specific presentation. They often start off with a very severe headache. Now, the CSF, so should they have a skull fracture where it leaks out, we can tell it's very bloody. If not, this is something that a LP can determine in a facility. Starts off as a really sharp headache, then it becomes a bit more across the head, followed by, you'll see pupillary changes. Now, I've seen them where it's literally constrict and dilate and constrict, constrict and dilate, and dilate and constrict. And that is the only time I've ever seen that is from a subarachnoid hemorrhage. The patient will then progress into posturing, followed by profuse projectile vomiting. So you have a patient who's unconscious, unresponsive, beginning to posture, and they begin to projectile vomit. This is a sign of intracranial hemorrhage, but also likely a sign of a subarachnoid more specifically. And when they get to the vomiting and posturing stage, the brain damage is generally incompatible with life. Now, your assessment of brain injuries. Now, we like to use GCS all the time on our PCRs, but GCS, Glasgow Coma Scale, was specifically designed for head injuries. So we actually use it very incorrectly the majority of the time. So for here, when it says flexion to pain, almost every practitioner here does this wrong. Flexion to pain is here. Extension to pain, out and away. So these are for decorticate and decerebate pathologies, not that, okay, I've twisted your arm and you flexed your hand. No, no, that is not what this needs. A lot of practitioners get this very, very wrong. So now you know flexion and extension directly relate to posturing and not just to a pain response. Now, if I pinch your shoulder and you move and you've withdrawn from the pain, that is a 4. But if I do a decorticate posturing, now I have a 3. So this is where a lot of practitioners get this wrong, and because you're taught right, now you're going to get this right. By the way, just for the heck of it, does everyone here know that after my head injury, guess what my GCS was? 3. I had a GCS of 3 for 3.5 hours. Remember, dead people get a 3 in our GCS score. So I'm very, very lucky. Now, moving right along. When we're assessing these patients, I want you, whenever possible, to redo your vital signs every 5 minutes. Now, my rationale for this is you can have dramatic changes in blood pressure, heart rate, respiratory rate, and consciousness with patients with, did I say patients? Patients with traumatic head injuries. One of your earliest indicators will be your pupillary response. When they are sluggish, something is wrong. Either they are drunk or they have the beginnings of cerebral hypoxia and the beginnings of increased intracranial pressure. The changes here in pupils where they are unequal, or one is getting bigger and the other one's getting smaller, and they're going back and forth. These are, as we know now, indications of a subarachnoid hemorrhage or intracranial hemorrhage. We want you to watch for this, note it, and this progression in our patients is very important. Now, when we assess our intracranial pressure, we cannot give you a clear indication of just how much pressure is in the skull during an ambulance call. We don't have the equipment to do so. That being said, once we detect the presence of posturing or Cushing's response or abnormal pupils or respiratory patterns such as Biot's or Cheyne-Stokes, we can be fairly confident we have profound intracranial pressure. How do we manage this? So we want to assume with this much of a head injury that there's a C-spine problem. We should consider doing a collar. Chances are these people will not be cognitive enough to be able to give you an appropriate response to, can you turn your head? Can you go up and down? Do you have any pain? No. So you should definitely just move to a collar. Make sure you assess your ABCs. Remember, with brain injuries, vomiting is of a great concern. So you need to be prepared with your manual suction and your battery suction. Remember, your battery suction will move more stuff, but if it fails, you need to have that handheld right beside you, because if something happens, you don't have it, you're going to have a talk. Now, using airway adjuncts at your level, consider using the oral pharyngeal airway. If they just have intracranial pressure without any signs and symptoms consistent with a basal skull fracture at the EMR level and other jurisdictions, you may consider using the nasopharyngeal airway. That's not an option here. Now, at your level, I would say use your manual maneuvers if you need to, your oral pharyngeal airway, but always consider calling for advanced life support, because to my knowledge, nurses do not have the ability to do LMAs, Kings, or ETs in the field. Am I correct in that assumption, Patricia?
I don't know for certain. I know we're not allowed at the hospital level.
Okay.
I
So,
think
yeah,
they can do King Airways.
There was talk of it, but I've never seen anyone complete the training course for it. So maybe it's happened. Maybe it's a conversation you should have with your local nursing team to determine what their scope of practice is. But whenever possible, you should consider getting Whitehorse's critical care flight team activated and on the route earlier than later, especially in MARSIC and CARCROSS, where we can reasonably arrive in a matter of time where a outcome can be improved. Now, monitor the depth, monitor the rate of your respirations. Remember, we want to monitor for what? Viots and Cheyne-Stokes. If we see decreased depth of respirations, we may need to consider doing our bag valve mask. So if they're unconscious and they are not having adequate air ventilations, we will connect our bag valve mask, connect it to oxygen flow, and we will begin to ventilate the patient. Now, generally, we want you to ventilate once every 5 to 6 seconds. If you have clear signs and symptoms of intracranial pressure, there has been a lot of controversy on this topic of whether or not we hyperventilate. For years we did, then for years we didn't, then for years we did again, then for years we didn't again. So there's a lot of controversy. And the reason why is if you're hyperventilating someone with a lot, and you're blowing up a lot of the CO2, it can cause some vasoconstriction, and it can temporarily, briefly alleviate some intracranial pressure. That being said, it is a last-ditch effort, and it doesn't work for more than 20 minutes anyway, in which case you're right back to square one. So the jury's out on this evidence. Our guidance is you will ventilate at around 10 breaths per minute. Follow your Yukon EMS clinical guidelines on this matter. And another thing to keep note of is you may have trismus. Now, do you all remember my little story about the traumatically injured patients from the motor vehicle accident where they were ejected in midair? Patricia, you remember that story? I did talk about it, right? Okay, so that patient, the second patient that I treated, his injury pattern with his brain injury made him trismic. So even trying to reef his mouth open as hard as we could, we were unable to open it. We could not get an OPA in. This is one of the times when I knew without a doubt he had a basilar skull fracture. However, there was no other airway we could possibly use in this patient, or he would have died without a doubt. That being said, follow your protocols. Because I worked in a place where I could work under a doctor's license to practice, and if they said I could do it, I could do it. We don't have that option here. Now, managing circulation, make sure that there is any major bleeding, use direct pressure. However, if it is a skull fracture or if it is a depressed skull fracture, will you do direct pressure? No, you will not. Please don't do that. Now, as we discussed before, these patients will benefit from a rapid transport. It is absolutely critical. We cannot appropriately manage intracranial pressure in the field. We can't even properly do it in a nursing station. And in fact, Whitehorse, Dawson, Watson cannot effectively treat this because surgical intervention is required. We need a center of neurosurgical capabilities. The only way they can get there is if you get them to Whitehorse early enough and if the crew is ready to go. And then hopefully we can transport them to a center that can deal with this. So we've covered a lot of content here today. Do we have any questions at this time that you would like to go over? Going once, going twice. Speak now or forever hold your peace. Oh, Patricia's got a question. Woohoo! How can I help Patricia?
When they talk about you mobilize them, but they're going to vomit and they want you to roll them, how exactly does that occur in the back of the car?
Can you speak a little bit louder? I couldn't quite hear that. How does what occur?
So you've stabilized their C-spine, you've got them packaged nice and tight.
Yeah.
Let's say they want to vomit. How do you roll them in the back of the car? Because you've got them attached to a stretcher.
Great question. So in the old days, when you were on a long spine board, that was very easy to do because we've secured you to the board with your head straps, your chest straps, your pelvic straps, your leg straps. Very easy. Grab the board, spin them over. Now, if you have a patient who you do not have on a board and you simply have on a mat, you have a couple of options. One, if they're still conscious and alert, have them sit up fully and have them vomit. If they're unconscious and we're now having to do all the work for them, you can, if injuries permit, articulate the head of the stretcher up fully. If injuries do not permit, you can use, I would actually suggest you have your partner pull over and then have them come into the back of the unit. One person maintains head control, the other one will help turn the patient, and then you will suction appropriately. Preferably, if you have a patient with these injury patterns, even if you're not using a backboard, there is no harm in utilizing the scoop stretcher because these patients likely will not be able to ambulate on their own. So I would say if you think that there is a risk for emesis, fancy word for vomiting, I would leave them on the board, and that way I can use that scoop stretcher to tilt them over in a more controlled manner and encourage vomiting, and then it's easier to suction as well. So that would be my suggestion to you. Does that answer the question?
Yeah.
Very good. With that in mind, let us stop the recording and start our next lecture because